Hi, I am Patricia Moulton, Executive Director of the North Dakota Center for Nursing, and I would like to introduce you to our Empowering Nurses to Lead, Every Nurse in Every Setting online leadership program. This program was developed by the North Dakota Action Coalition as a part of the Future of Nursing Campaign for Action.
Hi, I'm Cheryl Culber from the University of Mary, and I would like to share with you a little background on the North Dakota Action Coalition. The Action Coalition is a member of the National Campaign for Action that was actually established in response to the Institute of Medicine Future of Nursing recommendations. It is in conjunction with the AARP and Robert Woods Johnson Foundation. The action areas that resulted from the research of this particular Institute of Medicine report include leadership, nursing practice and care, the education of nurses, interprofessional collaboration, and diversity. Here in North Dakota, our Action Coalition has focused on the leadership development of our nursing workforce.
As Cheryl indicated, the North Dakota Action Coalition is focused on the leadership development area of focus for the national campaign. Over the last 2 years, we have been working in groups to develop leadership training that has been customized to the needs of North Dakota nurses. For more information about our Action Coalition, please visit the website listed on the slide. These leadership modules have been developed to be suitable for every nurse in every setting. The Action Coalition groups that developed these modules found that there are several key leadership skills that are shared by nurse leaders across every workplace setting. Increasing leadership in our nurses is important because nationally it has been shown that when nurses are positioned to influence system practices and policies, that this leads to improvements in the quality of care, wellness, and a reduction in medical errors. Nurses just like you have led innovative initiatives that have reduced falls with harm, reduced code blue calls, reduced 30-day readmissions, and improved care transitions. The North Dakota Center for Nursing and the Action Coalition encourages you to utilize your leadership skills as every nurse is a leader. Ways to share your expertise as a leader include volunteering with both healthcare and non-healthcare related committees and organizations. This can also include serving on boards. Speaking up in the workplace is also an important way to use your leadership skills and is a key factor in reducing errors. Speaking up is also important in the policy arena. We encourage you to pursue lifelong learning and to help mentor others as they start to develop their leadership abilities. Sharing the Institute of Medicine report is also a great way to start a conversation. You can also join the North Dakota Center for Nursing leadership team or the North Dakota Action Coalition. The North Dakota Action Coalition is co-led by the North Dakota Center for Nursing and the University of Mary Harold Schaefer Emerging Leaders Academy. The North Dakota Center for Nursing was established in 2011 and is a 501c3 nonprofit organization to create a unified voice for nursing excellence. Our mission is to guide the ongoing development of a well-prepared and diverse nursing workforce to meet the needs of citizens of North Dakota through research, education, recruitment and retention, advocacy, and public policy.
The University of Mary Harold Schaefer Emerging Leaders Academy is an experiential learning program for honors students who learn leadership skills in the context of their future career. In the School of Health Sciences, we work with all of the allied health sciences along with the pre-professional programs to help them to become servant leaders of moral courage. We have an advisory board of external representatives that help us with the outcomes of this program. There is an old adage which asks, are leaders born or are they made? Well, in reality, all leaders are born, as we know that we all enter the world in that way. But what's more important to realize is that leadership can be learned. It can be developed. It is everybody's business, and it is not inherent to a title. It is based on relationships, not a right given to you by a board or your executive manager. It is learned and is not a job. And you can always develop in leadership by adding more skills in an ongoing process. In nursing, for years we have spoken of nurse managers. And it's time we look at a new paradigm. We need to move into leadership. Nurses need to be at the table when important decisions are made at local, regional, or even national levels, decisions that affect the patients that they so closely advocate for. Managers are those people that keep things moving, and we need them. They focus on systems and on processes, and they make sure that things run smoothly. But I would like to challenge you to become a nurse leader, someone who has a vision, who innovates, who thinks about the future, and who challenges the status quo to bring ever better care to our patient population.
This online leadership program is divided into 4 modules that were developed for every nurse and in every setting. Each module includes slides with content, further resources, and additional information, along with a link to an evaluation survey for contact hours. Each module also includes a set of additional optional activities that are designed to help you apply what you have learned and to increase your leadership skills. Materials from these activities can be submitted for a completion certificate. Completion of all 4 modules will place you in a special leadership pool. The 4 modules include communication, that is foundational for learning and understanding about systems, knowledge of how systems function is necessary to institute change, and the ability to accept and engage in change is necessary to be an advocate for health policy.
Welcome to Navigating the Complex Health System, a primer for the nurse. My name is Joan Bachman. I'm a registered nurse, licensed nursing home administrator, registered health information technician, and a faith community nurse. The authors of this module have been meeting monthly by telephone conference since January 2014. Joan and Julie were co-leads of the Systems Thinking Group assembled following the October 2013 summit sponsored by the North Dakota Center for Nursing. Joan is the consultant who put words to paper and struggled to arrange the information into logical order. Joan is a management consultant, retired from many years of administrative level positions with hospitals, nursing facilities, and the survey agency for the state of South Dakota, and that's me. Julie is an instructor at Dakota State School of Nursing in Devils Lake. Eric is a med-surg staff nurse with All True Hospital in Grand Forks. Jenny is an advanced practice nurse with All True Hospital in Grand Forks. And Kelly is a nurse manager with the All True Clinic in Grand Forks. The broad range of their experiences help to give a broad perspective to this road to nurse leadership. The purpose of this module is to increase your understanding of how knowledge of the health system will help you, the nurse, provide patient-centered care to guide each patient toward desired health outcomes. This module, Navigating the Complex Health System, will look at the health system in terms of providers and services and how they are organized and regulated. You will gain insight into the difficulties encountered by a patient attempting to understand how to achieve a desired health outcome. The complexity of healthcare emphasizes the importance for the nurse to know what might be the desired long-term outcome by and for the individual, rather than dealing with only a current patient encounter. This module includes many internet links to definitions, examples, and lists that will be useful for your patient interactions. You are encouraged to copy and paste the links into your browser to expand your knowledge and understanding for the topics of greatest use to you. What is a complex system? A complex system is a system composed of interconnected parts that as a whole exhibit one or more properties, behavior among the possible properties, not obvious from the properties of the individual parts. This graphic depiction shows that a system has some connection between all elements. As we will see, because of the many elements of the health system, there is frequently no connection or even knowledge of the many possibilities and alternatives for making good connections for each individual patient. The complexity and lack of connectedness results in failure to concentrate on finding the best outcome for each patient, because individual elements of the system concentrate primarily on a single health concern of the patient at the time of that encounter. The complexity leads to increased potential for errors, missed opportunities, and unnecessary expenditures of the healthcare dollar by both the individual and the government. This module does not touch the whole realm of complementary alternative medicine practiced by many Americans. Complementary alternative medicine, or CAM, includes non-prescription drugs, nutrition, and health practices. What are silos? The American healthcare system isn't. It isn't a system. Patients have multiple providers. These providers rarely interact. The payment system operates in silos, and patient care isn't coordinated. We each know several pieces of the system, but may be unaware of many of the providers and services, or how to access another provider or service for our patients, or even for ourselves. Rather than participating in an organized system designed to ensure a healthy population, healthcare providers and practitioners are more apt to concentrate on their own specialties and population base. Healthcare has evolved into a capitalistic system that relies on competition rather than cooperation. This evolution is the result of many outside factors and doesn't necessarily reflect the professional view of practitioners and employees. Much of healthcare is driven by Medicare and insurance reimbursement rules. A silo indicates the patient is the point person who must keep track of what is necessary to take care of the problem that prompted this encounter. In other words, the patient has to recognize the problem, has to look for a diagnosis, has to put together the treatment plan, find his own follow-up, and worry about costs, particularly of transportation, lost days at work, and childcare. In a system, the patient would be surrounded by the elements that will address this encounter, involving the patient but not relying on the patient to put the pieces all together to continue life toward reaching the desired outcome. Nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations. Nursing is an important element in the healthcare system, primarily because of the personal nature of services provided for patients, and because nurses are present in most every provider type and involved with most every service. This definition of nursing clearly places the nurse in a leadership position to help individuals, families, and broader populations to obtain and maintain health. Medicare regulations for nursing facilities include the directive that should be central for every healthcare provider and service, and that is, each resident must receive and the facility must provide the necessary care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being in accordance with the comprehensive assessment and plan of care. What is the patient? The patient is lifestyle, physical abilities, diagnoses, treatment options, income, family obligations, hopes and dreams, culture, education, support systems, and much more. A patient is so much more than the present diagnosis. In today's environment, there is too often limitation on time to learn who the patient is, what the patient needs, wants, and expects. Intentional or not, the volume of patients, the organization of the healthcare delivery system, 9 to 5, Monday through Friday, holidays excluded, and the convoluted reimbursement mechanisms place the patient in an apparent position of being a commodity for profit rather than the focus of the system. Nurses are in the best position to take a leadership role in patient care and services to return the focus to the whole patient. The patient is the reason we are nurses. We have a clearer understanding of what a patient needs and expects when we or a family member are a patient. I remember quite vividly how my attitude and ability as a delivery room nurse changed after I gave birth to my first child. Personal experience remembered can benefit our patients. Knowledge of the system. The problem is there are inadequate handoffs in which safety often fails first. Nurses are the healthcare professionals most likely to intercept errors and prevent harm to patients, and often are not permitted to do that. The solution. is to be aware of the many facets of the system, to recognize how things work and why, to know who is responsible, to realize complexity barriers as seen by you and as seen by the patient, to know that patients may need help to identify sources of service and need help making decisions. Nurses are in a powerful position with any segment of the health system to assist patients to make wise decisions regarding healthcare services. Given sufficient information and time, if every nurse emphasized personal responsibility and prevention by assisting patients to look to the future, the nurse would have the opportunity to improve quality of life for patients. Objectives. We have 4 objectives for this module. Number 1, review the healthcare system's provider types and levels of service, regulation, and reimbursement mechanisms. 2, investigate your organization's structure and processes. 3, describe your position or role within the organizational structure. And 4, demonstrate your knowledge of the healthcare system to help a patient and family consider and access viable options for achieving personally desired health outcomes. Objectives for this module are intended to broaden the scope of your ability to be a leader in your present position, to make for the best possible quality for each patient, and to know that your leadership skills can positively impact a larger segment of your own professional life. Objective 1 is to review the healthcare system's provider types and levels of service, regulation, and reimbursement mechanisms. First, we'll look at the system in terms of provider types. Community providers are those that are generally available to the community at large or to qualifying segments of the population for prevention, support, or treatment. Outpatient providers offer treatment and services to patients who remain less than 24 hours. The inpatient provider admits the patient to remain overnight for treatment, support, and lodging. In-home care providers offer prevention, support, and treatment services in the individual's private home or in a current place of residence, such as a group home or assisted living facility that does not prohibit such services. Provider ownership and management. There are general providers and special population providers. Note that healthcare is a significant business traded on the stock market. Centers for Medicare and Medicaid Services, or CMS, reports healthcare spending at $2.8 trillion in 2012. That's $8,915 per American person, more than 17% of all expenditures in the United States. For purposes of this slide, the term provider is used to describe both licensed healthcare facilities or agencies and the most common mainstream individual practitioners. General providers are those most available to the general population and may be owned by religious organizations, the community, generally as a nonprofit organization, private individuals, or a business structure such as a corporation or a partnership, or the government, which may be local, state, or federal. And special population providers, which may be owned or managed by government or by nonprofit or for-profit organizations. Examples are the Veterans Health Administration, Indian Health Service, Migrant Health Services, Public Health Services, group homes, and homeless shelters. The information on organizational systems is shared to help you understand that in addition to the ownership and legal structure of the individual providers, there may be cooperative relationships between some providers in the state. These relationships may have some effect on how patient referrals are made. A single facility system of services example would be Prospective Pay Hospital, which offers some or all of these services under the hospital license. Emergency, med-surg, obstetric, neonatal, surgical, coronary care, critical care, pharmacy, psychiatric, transitional care, rehabilitation unit, and palliative care. Not many hospitals offer this full range of services. Co-located facilities would be locally owned facility continuum, which offers hospital, clinic, nursing facility, assisted living, home health, and pharmacy. This system is most often seen in rural communities. And then there are owned and managed systems, regional parent organizations such as Sanford, Altru, Essentia, Trinity, St. Alexis, that owns and or manages hospitals, clinics, nursing facilities, assisted living facilities, home health, hospice, pharmacy, and wellness center. It would be good if you would determine which system you belong to. A note here, pharmacies are actually not licensed within the hospital but require a separate license if they are retail. Community health providers is a loose term used here to give an idea of the many community providers and agencies. Many of these providers are located in larger communities and may not be accessible to all North Dakotans. The public health system in North Dakota includes the Department of Health and 28 local health departments and local health districts, tribal governments, and other partners who network to improve the health of the population. Rural health clinics, or RHCs, and federally qualified health clinics, or FQHCs, are specially designated by the federal government based on population within a defined geographic area. The system of reimbursement for services is affected by CMS, the Centers for Medicare and Medicaid Services. WIC, the Federal Special Supplemental Nutrition Program for Women, Infants, and Children, is an income-qualified service aimed at good health for women and infants. Home health services may include personal care service as well as nursing and therapy treatment services. School nurses, faith community nurses, and foot clinics offer services and may also serve as advocates for defined groups of individuals within the community. Vaccinations are offered by a variety of qualified providers, often for flu or to prevent some other potential epidemic. Wellness and fitness centers are important to personal health and prevention programs and may accept referrals for aftercare. Many employ personal trainers to guide individuals to safe activity levels. Social service and mental health agencies found throughout the state are large and small, connected or not connected to other providers and services. In addition to the previous slide, there are additional community providers. Durable medical equipment suppliers provide a wide variety of equipment to assist patients to receive certain services where they prefer to receive them. Suppliers usually make deliveries to the patient. Pharmacies offer personal access to health products and to the pharmacist. Industrial health clinics may be organized for only one business or may be operated for the general public. Shelters and halfway houses offer lodging, and many offer counseling and life skills training for defined populations. Foster care may be available for protection and support of children or vulnerable adults. Adult daycare and respite care providers offer a variety of daytime services for a variety of special diagnoses or conditions such as Alzheimer's disease or mental health and substance abuse issues. A particular benefit may be realized by an at-home caregiver. Respite care may also be continuously available for several days. Group homes offer lodging, meals, and selected services for a variety of special diagnoses, such as mental health and substance abuse issues. Community action agencies offer services to help people to help themselves in achieving self-sufficiency. The Community Action Agency is not a provider of healthcare services, but because of the services it does offer, may be an advocate for someone with health issues and may act as a referral agency. Outpatient providers include medical clinics. There are an estimated 305 in North Dakota. Ambulatory surgery centers, there are 12. Most hospitals offer outpatient services, and there are physical therapy and occupational therapy outpatient providers. The websites for listed regulated providers are available for your access. Note that medical clinics have no regulatory oversight with exception of professional licensure and diagnostic services. However, the rural health clinic and federally qualified health clinic are regulated by the federal government because of their reimbursement contracts. The number of patient visits here, 3,679,739, is provided for only hospital-based clinics. Ambulatory surgery centers offer outpatient services for surgical and diagnostic procedures. They may be affiliated with another provider or freestanding. Hospitals offer an array of outpatient services for diagnosis and treatment, with 1,702,820 outpatient visits in 2012. Physical therapy and occupational therapy clinics may be affiliated with a licensed facility or agency, or may be privately owned and freestanding. In addition to the previous slides, there are outpatient providers also include audiology and speech-language pathologists who may be affiliated with a licensed or certified facility or agency, a school system, or may operate privately. A dietitian nutritionist may be affiliated with a licensed facility or agency or may operate privately. North Dakota has only one comprehensive rehabilitation facility, or CORF, in Minot. A CORF provides diagnostic, therapeutic, and restorative services to outpatients by or under the supervision of a physician. North Dakota has 54 addiction and mental health outpatient therapy services, some of which may be provided by inpatient providers. In addition to licensed addiction and mental health therapy providers, remember there are support organizations such as Alcoholics Anonymous, Narcotics Anonymous, Gamblers Anonymous, and so on. Contact with these support organizations may not be readily available. Your local ministerial association may have contact information on those organizations. And the list of outpatient providers continues with renal dialysis centers, which offer dialysis to individuals with diagnosed chronic kidney disease. These centers are not to be confused with inpatient dialysis for hospitalized patients. There are many diagnostic and screening services generally provided by any medical clinic, ambulatory care center, or hospital outpatient department. There are also mobile radiography services throughout the state. Screening clinics may be held in the community by a variety of providers or agencies and offer a variety of screening services. Telemedicine noted here includes the transmission of diagnostic studies transmitted from a primary site to a specialist. An example being an X-ray taken in a rural health clinic, transmitted electronically to a distant radiologist. And there are more outpatient providers in addition to those previously listed, including adult daycare and respite care, which may be offered by nursing facilities, assisted living facilities, or home health agencies. These providers may also offer in-home services, such as respite care and personal care services. Reflexologists and massage therapists may operate independently or with other licensed health providers. Hearing aid dealers generally operate independently, but may make visits to clients or potential clients. Additional outpatient providers include cardiac and wellness centers, which may be freestanding or affiliated with a licensed facility or agency, and may offer training and supervision of an individual's physical fitness activities. Chiropractic clinics are generally freestanding and may offer additional physical services such as massage and acupuncture. Pharmacies in North Dakota must be owned by a pharmacist. That ownership requirement is currently being challenged. Information regarding telehealth services availability for your patient may need to come from your employer. Inpatient providers offer services which exceed 24 hours. North Dakota has 51 hospitals which admitted 97,023 patients in 2012. There were 337,451 emergency room visits during that year. There are several designations of hospital defined by federal and state regulations. Acute general hospitals include the 6 prospective payment hospitals, which are held to what may be called original or full federal and state hospital standards of licensure and certification. PPS hospitals are reimbursed by Medicare based on average costs associated with diagnostic-related groups, DRGs, and current procedural terminology, or CPTs. And there are 37 critical access hospitals which have 25 or fewer beds and have an average acute length of stay of up to 96 hours. They are held to amended federal and state standards and are reimbursed by Medicare on a cost basis. This hospital designation was first certified and licensed in 1997 to retain financially viable acute inpatient care in rural America. Swing beds are inpatient acute beds that may offer reimbursable long-term care, nursing facility level of care, permitted within the licensed 25 beds. As a point of interest, when I managed the South Dakota Department of Health Survey Agency, we licensed and certified the first critical access hospital, then called a Rural Primary Care Hospital, or PEACH, in the United States. We came in ahead of West Virginia by 1 day. There is one licensed rehabilitation hospital. Some PPS hospitals may offer rehabilitation services under their licenses. There are 2 long-term acute care hospitals, or LTACs. LTACs furnish extended medical and rehabilitative care to individuals with clinically complex problems, such as multiple acute or chronic conditions that need hospital-level care for relatively extended periods. Average length of stay exceeds 25 days. This designation of hospital was first certified more than 20 years ago. North Dakota has 3 acute psychiatric hospitals and 2 transplantation hospitals. North Dakota has 80 licensed and certified skilled nursing facilities which provided services for 12,213 residents during 2012. North Dakota requires all nursing facilities to be both Medicare and Medicaid certified, not a requirement in many other states. The majority of nursing facilities in North Dakota are not for profit, unlike much of the nation. To continue the list of inpatient providers, North Dakota has 103 facilities licensed to provide services for individuals with intellectual disabilities. They may house and support individuals or also offer training and job opportunities. Basic care facility focus is to provide room and board and health, social, and personal care to assist the residents to attain or maintain their highest level of functioning, consistent with the Resident Assessment and Care Plan, to 5 or more residents not related by blood or marriage to the owner or manager. These services shall be provided 24 hours a day. Basic care may be co-located with a nursing facility or an assisted living facility. Basic care in North Dakota is similar to assisted living facilities in most other states. The assisted living facility is a building or structure containing a series of at least 5 living units operated as one entity to provide services for 5 or more individuals and advertised to provide or coordinate services to assist the individual to maintain as much independence as possible. This facility type must adhere to Department of Health food and lodging requirements. Assisted living is licensed by the Departments of Health and Human Services. North Dakota has no inpatient hospice facility, but hospice may provide services to long-term care facility inpatient residents. And still more inpatient provider types. Treatment centers offer professional services to individuals with mental health disease or addictions. And group homes provide living arrangements and health and support services for a variety of special populations, including those with mental illness and a variety of disabilities, including traumatic brain injury. In-home providers include home health, of which there are 35 in the state, therapies, physical, occupational, respiratory, and speech language. Hospice, there are 13 licensed in the state, and homemaker services. In-home providers may offer services in an individual's personal home or apartment or in a congregate housing location that is neither required to nor prohibited from permitting these services on the premises. Family and friends provide the majority of in-home care and support. Independent healthcare practitioners include physicians, of which there are 3,323, and there are 279 physician assistants. There are 455 dentists, an unknown number of pharmacists. 558 of the advanced practice nurses have prescriptive authority, and there are optometrists and opticians. Independent health practitioners may or may not operate in conjunction with another practitioner or with a provider. By virtue of licensure, they may practice independently within the described scope of practice. See the internet links for scope of practice for each practitioner type. There are more independent practitioners, chiropractors, psychologists, counselors, addiction counselors, and podiatrists. And a third slide listing independent health practitioners includes massage therapists, reflexologists, audiology and speech-language pathologists, and hearing aid dealers. Note that some practitioners were also listed as providers because they may also be available as a Main Street business. We will look at the health system in terms of services offered by the providers previously listed. Preventive services are intended to prevent or delay acute illness and to prevent, delay, or manage chronic conditions. Acute care services are offered to treat or cure currently occurring medical conditions of an acute nature. Rehabilitative care refers to healthcare services that work with patients to keep, restore, or improve skills and functioning for daily living, and skills related to communication that have been lost or impaired because a person was sick, injured, or disabled. Chronic care services treat long-standing, non-curable disease with treatment, education, and support services. Chronic care services manage rather than cure disease. Palliative care is specialized medical care for people with serious illnesses. It focuses on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis or prognosis. Long-term care means a variety of services which help meet both the medical and non-medical needs of people who have a chronic illness or disability and who cannot care for themselves for long periods of time. End-of-life care is for individuals facing a life-limiting illness or injury. Hospice and palliative care offer a team approach, offering expert medical care, pain management, and emotional and spiritual support tailored to the person's needs and wishes. Support is also provided to the person's loved ones. Preventive services are offered in a variety of settings depending on your particular community. Community services may be offered by any of the 18 provider types listed in slides 12 and 13. Services may include treatment, education, referral, family service, and referrals for domestic, legal, and financial issues, support groups such as an Alzheimer's group, and nutrition such as Meals on Wheels. Community services are usually specialized to meet an identified need. Wellness centers may be available to the general public or may require a membership. They offer equipment for physical exercise and training and may be staffed with trainers who provide education and support. Medical clinics, hospitals, and outpatient providers may offer screening, diagnosis, education, and referrals for disease prevention or to delay disease complications. Some may also have organized support services. Physical activity, offered by a variety of therapy practitioners, offer diagnosis, treatment, training, education, and referrals to delay or eliminate the need for surgical intervention. These practitioners may also provide patients with pain relief through physical rather than pharmaceutical means. Acute services may be defined as those aimed at providing short-term treatment for an episode of illness or severe injury. A medical clinic is usually the first visit a patient makes to deal with a self-identified acute medical problem. The clinic offers treatment and diagnosis for acute conditions and makes referrals as necessary. The clinic may or may not accept emergency patients and may or may not offer education and follow-up services. Ambulance, first responders, and other emergency providers such as firefighters, police, Homeland Security, Red Cross, Salvation Army, and so on, may be activated by the patient, a provider, or other agencies, including the government. The acute service is usually followed by referral. Hospitals are required to offer diagnosis and treatment for emergencies and to offer inpatient service for other acute health problems, including scheduled and unscheduled admissions, diagnosis, treatment, education, referral, and follow-up. Outpatient providers offer scheduled diagnosis, treatment, education, referral support, follow-up, and follow-up for acute health problems. Chronic care services include education and management of chronic disease or health condition. Our current healthcare system emphasizes treatment of acute conditions rather than management of chronic conditions. The nurse in any setting can educate the patient to participate in chronic care management. The medical clinic offers screening, diagnosis, treatment, education, and referral for management of chronic disease. Hospitals are generally involved in the acute phase of a chronic condition or its complications, offering diagnosis, treatment, education, palliative care, and referrals. The end-stage renal dialysis unit, or ESRD, offers treatment and support for persons with diagnosed chronic kidney failure. Long-term care services are offered in such places as nursing facilities, basic care, assisted living, and home health services. They provide diagnosis, treatment, education, personal care, palliative care, and support for persons with chronic disease or condition who are no longer able to manage their personal health needs and activities of daily living. In-home services include treatment, personal care, palliative care, and support for chronic conditions. In-home may be interpreted to also mean a lodging facility that the person now calls home, such as assisted living, provided the license for that facility does not prohibit such services. Community providers and agencies may provide treatment, education, meals, daycare services, support, transportation, and referral for persons with chronic health conditions. Long-term care generally offers limited medical services, as for chronic conditions, and concentrates on personal care and assistance with activities of daily living for persons unable to continue self-care. Assisted living facilities provide lodging and meals and may offer supervision and optional services such as medication management for individuals with some level of independence. Basic care facilities offer lodging, personal care, medication management, nutrition, and activities for persons who are capable of self-preservation and whose condition does not require continuous 24-hour-a-day on-site availability of nursing or medical care. The nursing facility offers lodging, personal care, treatment, and skilled nursing for persons who require 24-hour nursing services because of disease or condition. In-home long-term care services may be offered by a variety of providers and include personal care, treatment, skilled nursing, patient and family support. Group homes offer long-term housing for treatment, support, and supervision for persons determined to require 24-hour services. Group homes serve persons with specific conditions, including mental illness, developmental delays, traumatic brain injury, or addictions. The North Dakota Department of Human Services is most involved with the group home provider group. In-home services have existed since the beginning of human life. About a century ago, there was a decline in home care in favor of institutions and agencies. However, recently, because of cost and reimbursement issues, there is increasing interest in providing services in the home. This may also be a social or generational change. The nurse should be aware there is the potential for abuse of the patient in the home setting and report any suspected abuse to supervisors or the proper authorities. If you have questions, you may contact the North Dakota Department of Human Services. Personal care includes assistance with or performance of activities of daily living and instrumental activities of daily living. Personal care may be provided by family, privately hired individuals, or an organized reimbursable service such as home and community-based services. Nutrition services may include Meals on Wheels or grocery delivery. An important side benefit of this service is the unofficial oversight by someone from outside the home. Telehealth services may be available, such as medication management, cardiac monitoring, and so on. Check with your employer to learn if such services are available for your patients. Homemaking services may be provided by family or a paid organized service, sometimes reimbursable. More in-home services include home health, which may be provided following an episode of acute or rehabilitative services. Home health includes skilled nursing care, physical, occupational, respiratory therapy, or speech-language services. It may be possible to arrange for in-home diagnostic services, such as lab draws and mobile radiography. Check with your employer to learn if such services are available for your patients. This service can offer major cost savings to the patient related to transportation and paid attendance, as well as saving the patient from unnecessary pain. Who defines providers and services? The government has a duty to protect the public and serves as the safety net for people who need and use healthcare services. The federal government entered the healthcare arena in 1965 with the Social Security Act. This included Medicare and eventually Medicaid. Regulations that govern health care may be written and enforced by either the state or federal government. If a state regulation is weaker than the federal regulation prevails, and vice versa. It is the responsibility of the regulated entity to be aware of the scope of practice and limitations imposed by the laws and regulations. Government does not have a clear duty to inform each regulated entity of changes in the regulations. Professional associations often make members aware of such changes. The state legislature passes laws in response to public input. State departments are authorized to enforce the laws and write regulations to describe how citizens must comply with the law. The Department of Health has a contract with the federal government to regulate healthcare facilities and some providers, not practitioners, in North Dakota. The Department of Human Services is responsible to provide or reimburse for a wide range of services for individuals of all ages, particularly those who are vulnerable. Department of Human Services is the Medicaid agency for North Dakota. Each licensed health professional is regulated by a board or commission. For example, the Board of Nursing regulates the practice of nursing, the Board of Pharmacy regulates pharmacists and the practice of pharmacy. The Board of Medical Examiners regulates the practice of physicians and physician assistants. There are many more boards that regulate the practitioners listed earlier. The regulatory websites were included on the slides listing those practitioners. Congress passes federal laws in response to public input or perceived need. Federal departments are authorized to describe and enforce the laws through written regulations. The federal agencies most involved with health care include Health and Human Services, which is the parent agency for the Centers for Medicare and Medicaid, Food and Drug Administration, Centers for Disease Control, and Indian Health Service. Other relevant agencies are the Drug Enforcement Agency, Occupational Safe and Health Administration, or OSHA, and the Department of Labor. There are many more federal agencies. These agencies are authorized by Congress to write regulations interpreting the law and to enforce compliance by the regulated entity. There are more outside forces. Unlike most business models, Healthcare is subject to many outside forces that may or may not be primarily involved in the business of providing health and medical services. This intense outside pressure doesn't always contribute to provider and practitioner development of patient-friendly services. Governing bodies of a facility, such as the board of directors, owners, medical staff, and department heads, establish the direction, determine the scope of services, determine the financial status, and establish the personality of the agency. Professional associations keep membership informed on changes and regional or national issues. They advocate for providers with legislative lobbying, offer education, and afford peer support. Provider organizations keep the membership informed on changes in regional or national issues, advocate for providers with legislative lobbying and marketing efforts, offer education, and afford peer support. Institutions of higher learning contribute to the attitude and abilities of students as well as providing knowledge. They perform research that leads to new treatment and technology, develop clinical expertise and standards, and contribute to standards of ethics. Payers of service define elements of service, that is, allowable and covered versus non-allowable or non-covered, not always coherent with standards of clinical practice and regulations. Government pays for a lion's share of the health care that is delivered and determines what is covered and what is not. Insurance companies have stockholder profit motives to help them decide what is covered and what is not. Public perception is influenced by provider advertising and word of mouth. This perception leads to public demands for service and may encourage pursuit of legal remedy for perceived errors. The general public who utilize healthcare services seem inclined to rely on the healthcare delivery system to fix them when something goes wrong, rather than to assume personal responsibility for personal health status. The nurse can make some inroads into that perception. Patients and customers have the most limited impact on governing the healthcare system, except by seeking alternative providers. The regulation of healthcare. Healthcare facilities and practitioners are regulated with specific permissions and limitations, or scope of practice. The intensity of regulation for nursing facilities is reportedly second only to that of nuclear energy. States issue licenses that describe the scope of service and enforcement methods for compliance. The license establishes the standardized definition within the state. Definitions of practice are not consistent from state to state. Compliance with licensure requirements is evaluated by the licensing agency. The federal government grants certification to certain qualifying facilities and agencies to describe a service and the payment mechanism. The Social Security Act mandates the establishment of minimum health and safety and clinical laboratory improvement, or CLIA, amendments that must be met by providers and suppliers participating in the Medicare and Medicaid programs. These standards are found at Code 42 Federal Regulations, or CFR 42. Some individual providers and professions may be federally certified when no state licensure requirement exists. End-stage renal dialysis, or ESRD, is a North Dakota example of certified but not licensed provider. Certification requirements for compliance with Medicare and some Medicaid providers are enforced under contract with the Department of Health. Certification requirements for compliance with some Medicaid providers are enforced under contract with the North Dakota Medicaid Agency within the Department of Human Services. Accreditation is a voluntary designation purchased by healthcare facilities. The accrediting body, such as the Joint Commission, has no legal authority unless contracted with a licensing or certifying agency, such as the Centers for Medicare and Medicaid. Accrediting standards are based on legal federal requirements and clinical standards of practice. Enforcement of regulations. The enforcement of regulations for healthcare services continues to grow, perhaps in concert with increasing costs and mobility of the population. The state legislature grants to departments and boards the responsibility and authority to enforce compliance with regulations, and the authority to take punitive action when noncompliance is reported or discovered. Congress grants federal agencies the responsibility to enforce compliance and authority to take punitive action. The Centers for Medicare and Medicaid, or CMS, has delegated the initial enforcement for compliance with certification requirements to the states, reserving the right to take enforcement action. The action taken by the regulatory authority when discovering noncompliance may begin with acknowledgement of the noncompliance described in a letter of reprimand from the agency to the provider. When specific findings are documented, the regulatory agency may request a plan of correction and issue a warning of possible consequences if the plan is not completed. There may be notification of the specific noncompliance to other agencies and to the public. Civil money penalties or fines may be suggested or required by law. In some cases, the scope of practice of the subject may be limited, such as eliminating obstetric services from a hospital or denying certain surgical privileges to a surgeon. Reimbursement for services may be denied in some cases, such as a nursing facility will not be paid for any new Medicaid admissions for a specified period of time. At the extreme, a license or certification may be revoked, and/or the subject may be prohibited from future participation in the healthcare system. Reimbursement for health services. The reimbursement for health services has a significant impact on the entire system and on the types of services offered to patients. In most cases, the patient is required to establish eligibility before the service is provided. Private health insurance coverage has many variations. Insurance plans are regulated by the North Dakota Department of Insurance. Premiums may be paid by the insured or by the employer. Payment is made for covered services provided by a participating provider. Premiums and payment rates are determined by the types and level of service that will be paid for by the insurance company. Premium rates are based on experience of the insured population, which means different groups may have different premiums for the same level of service with the same providers. For example, a group of young people may pay a lower premium than a group of older people for the same service with the same provider based on care requirements, such as for chronic health conditions. Private self-pay may result from a personal patient decision to not carry insurance or from lack of coverage by the insurance or by government. Self-pay status is most generally for uninsured patients. A patient may also choose to pay for non-covered services if the provider will perform those services. There may be provision for a sliding fee scale for certain patients and services based on personal income. Free care may be offered to some patients by providers. Medicare is the federal insurance program for persons who are qualified by age and/or disability who have contributed to the program. Medicare makes pre-established payment for covered services provided by participating qualified providers. Reimbursement rates are based on reports of actual costs from previous cost reports. Medicare will pay no more than the lowest charge for a service. Medicaid is the federal insurance program for persons who are qualified by income, age, and disability. States are required to contribute a portion, the Federal Medical Assistance Percentage, or FMAP, of the total reimbursement rate for Medicaid. State legislatures determine the rate of state match. In 2012, the federal government contributed 55.4% toward Medicaid expenditures in North Dakota. Medicaid makes pre-established payment for covered services provided by participating qualified providers. Reimbursement rates are based on reports of actual costs from previous cost reports. Many providers refuse to accept patients covered by only Medicaid, as the reimbursement rates may be lower than operating costs. Population-based reimbursement programs, such as the Veterans Health Administration for qualified veterans, Indian Health Services for qualified Native Americans, Migrant Health Services for migrant farm workers, and Public Health Services to provide essential health care services to underserved and disadvantaged populations. Reimbursement for services under these programs is made for specific covered services and to specific participating providers. Definitions. Although the nurse is seldom involved in reimbursement transactions, it may be helpful to be familiar with reimbursement terminology and definitions. Covered services. Medical and healthcare services are defined by the paying agency. Restrictions vary by paying agency and specific coverage plan. In other words, a service may require a specific sequence of diagnostic tests or treatments to qualify for payment for a treatment. Or B, payment may be made for a specific treatment for only a specific diagnosis. Neither the insured patient nor the provider or practitioner decides what is covered service, although both agree by virtue of the contract with the paying agency. Participating providers or practitioners are legally qualified providers and practitioners who have an agreement with the paying agency for certain services under certain conditions. Qualified providers and practitioners are those who are licensed or credentialed to perform the service for which payment is requested. Prospective payment system is a means of determining reimbursement to hospitals based on predetermined prices, commonly determined by Medicare. Payments are based on codes such as the diagnosis-related groups, DRGs, bundled, ambulatory payment classifications, APCs, bundled, or current procedural terminology, CPTs. The bundled terminology means that the study has included all of the items necessary in providing for that group. Fee-for-service or cost-based reimbursement is made for individual unbundled services and supplies, which are charged separately based on a predetermined rate, but not predetermined usage. More reimbursement definitions include premium, which is the payment by the insured to the insurer for selected level of coverage. Deductible is the contracted dollar amount to be paid by the insured before payment is made by the paying agency. Medicare Part A is Medicare coverage for hospital stays and for end-stage renal dialysis. Medicare Part B is Medicare coverage for covered outpatient services. I found no Medicare C plans in North Dakota. Medicare D is the Medicare drug coverage plan. Copay is a dollar or percentage amount the insured has agreed to pay for covered health services. This is different than a deductible. Examples of copay arrangements include your copay for prescription drugs. On the horizon, there are articles about medical homes. Medical home is a patient-centered medical home similar to managed care and health maintenance organizations, but focuses on improving care rather than managing costs. The personal physician coordinates care using practice management, health information technology, quality and safety, practice-based care team, care coordination, care management, practice-based services, and access to care and information. There are a couple of articles cited there that are worth reading. Nurse-managed health clinics could improve access to comprehensive primary health care services and/or wellness services. In other words, disease prevention and health promotion across the lifespan, especially in medically underserved areas. A nurse-managed health clinic could also serve as a primary care training and data collection site. The overall effect of the Affordable Care Act, or Obamacare, is unknown at this time. The overall cost of health care is projected to increase substantially over the next couple of years. The nurse-managed clinic would seem to be an excellent result of the Affordable Care Act. This study cited by the Health Resources and Services Administration, or HRSA, is good reading. North Dakota's Mary Wakefield is the administrator of this agency of the U.S. Department of Health and Human Services.
Hello, my name is Jenny Sentai. I'm a clinical nurse specialist at All True Health System, and I'll take you through the objectives 2 and 3. The second objective for this module, Navigating the Complex Health System, is for you to investigate your employer's organization's structure and processes. It's good to know and understand who it is that you represent every day on the job. Ask your supervisor where to begin to find the information that describes your employer. There may be information in the employee handbook, the annual report, or on the organization's website. The information should include the legal description of your employer as defined by regulations. For example, it's a nursing facility, clinic, public health. Most, but not all, health organizations require a license which must be posted in the place of business. If the provider accepts Medicare or Medicaid reimbursement, there is evidence of certification. Accreditation may be required by the owner. Accreditation is not a legal requirement, but may be a business requirement. The Joint Commission and other accreditation agencies may be contracted by the federal government to verify compliance with regulations. The organizational structure may require a bit more study to learn. Who owns the business? What are the legal descriptions of the owner structure? Is the business organized as a for-profit or non-profit? Non-profit is exempt from some taxes. Non-profit must still make a profit, but it's invested back into the business rather than going to stockholders of the business. Does the owner have more than one place of business? Provide more than one type of healthcare service? Some federal programs may require special organizational structure. States describe elements necessary for the variety of ownership types. If a facility has more than one site, it may be necessary for each site to be specifically described either legally or organizationally. When a business or practice relationship exists between providers or practitioners, there may be a requirement to disclose that relationship. Organizational governance gives details as to who is ultimately responsible for how the business operates. This may be an individual or a board of directors. A mission-vision statement generally exists to describe the business, ethical, and moral philosophy of the owners and governance. This information will generally be included in the annual report of the business, perhaps on a website or promotional materials. Employees should be familiar with the requirements and philosophy of the employer. It's helpful for you to understand how the departments and functions within the organization are related and how they communicate, the chain of command. You will be able to use this information to develop and promote your leadership skills. Often politics may interfere with the mechanics of the official organizational chart, causing conflicting messages to employees. The annual report and the website of your employer will contain a description of services and the target population. It may also describe relationships with agencies and the public within the community. The Personnel Handbook will describe the system of management and reporting requirements from the organizational chart and employment policies. Descriptions of policies, procedures, and quality systems as related to your relevant role is readily available to all employees in either hard copy or digitized. Familiarity with and regular utilization of these resources saves time, increases safety, and saves money. The resources should be current and complete. Learn to report discrepancies and outdated materials to your supervisor or to the person or committee responsible for these documents. The third objective is to describe your position or role within the organizational structure that you just described. The Department of Nursing is generally the largest group in an organized healthcare organization. Although it is critical for the nurse to know all the intricacies of the assigned job, much of each day's work is more clear if you understand the entire department. In addition to the primary responsibility of nursing care and personal care of the patient, responsibilities of the Department of Nursing may include infection control and patient education. Nursing is also closely connected to quality assurance and compliance, safety, utilization of resources, and patient satisfaction with services. A strong Department of Nursing relies on a sustained departmental sense of direction rather than being dependent on the personality and management style of the nursing service administrator. When most every nurse is willing to become familiar with the broadest understanding of departmental functions and take a leadership position in the Department of Nursing, that department has a stronger influence on quality of care for each patient. This leadership should have no negative effect on management of the department. What do nurses really do during the course of a workday? This depiction of a nurse's role in the hospital is the result of a study led by Dr. John Kennedy during his long rehabilitative stay in a large general hospital. His book, Designed to Adapt, is listed for recommended reading. You may relate to this to some extent. 43% of time is spent in clarifying, hunting, rework, redundancy, checking, waiting, fetching, etc. 24% of the time is spent on administration such as charting and computer data entry. That leaves only 33% of the day in face-to-face time with patients. You certainly have ideas for decreasing the largest use of time by identifying the root causes for spending 43% of your time doing non-productive tasks. The Change and Innovation module, which follows this module, will help you participate in making operational changes to individual systems in your immediate work area so you'll have more time available for face-to-face patient contact. As a nurse with patient care responsibilities, you have more freedom to affect patient care than you may realize. Consciously use all your nursing skills: assessment, nursing diagnosis, planning, implementation, and evaluation for each patient. Be mindful, be in the moment, observe without being judgmental, reflect on what you see and hear, know that you don't know everything. Use your personal skills and personality to influence from where you are today for this patient today. Empower yourself, coworkers, and patients to reach goals. Teach, facilitate, coordinate the work environment, relationships, patient services. Your patient looks to you for direction and advice. Know the patient well enough to understand and guide. Be trusted, reliable, honest, and trusting. Be accountable and responsible to follow through for each patient. Know what your patient's desired outcome is from this encounter. The fact of rotating nurses in some patient care settings makes the coordination of care between caregivers absolutely critical. The care plan should be explicit for each patient and referred to by every caregiver at the beginning of each encounter for a handoff that benefits the patient. It's crucial that nurses communicate fully regarding each patient. Do not keep secret your special techniques or connections, but share them for the best patient outcome. When preparing the patient for discharge, include all available information to make a good transition to the next steps of patient care and well-being. More about handoffs will be discussed later in this module.
Hi, my name is Eric Christofferson. I'm a registered nurse on a medical surgical unit at Altria Health System in Grand Forks. Today I'll be covering objective number 4 with you. This fourth objective incorporates the foregoing information into your application of the nursing process for each patient. Nurses have the opportunity to positively influence health and well-being for individual patients and families with intentional handoffs. We will consider the barriers that you may encounter as you assist patients. Remember that without your help, the patient must navigate through these barriers with less knowledge and fewer connections than you have. The patient has the primary burden of fitting the diagnosis into a whole life scheme.
Can I also have you say objective 4 for me, just real quick?
Oh, yeah. Objective 4. What is nursing process? Nursing process, a 5-part systematic decision-making method focusing on identifying and treating responses of individuals or groups to actual or potential alterations in health. Includes assessment, nursing diagnosis, planning, implementation, and evaluation. What is a handoff? A successful handoff is defined as a transfer and acceptance of responsibility for patient care that is achieved through effective communication. It is a real-time process of passing patient-specific information from one caregiver to another or from one team of caregivers to another to ensure the continuity and safety of that patient's care. A handoff process involves senders, the caregivers transmitting patient information and transitioning care of a patient to the next clinician, and receivers, the caregivers who accept patient information and care of that patient. Look at what is happening from the patient's perspective. Although this information relates specifically to hospitalizations, the patient's experience with other providers and services is similar. Patients are not being prepared for the next steps following a patient encounter. Every person involved in the care of the patient has an opportunity to make the current patient experience be positive and productive, and to prevent unplanned events following discharge. As a staff nurse on a medical surgical unit, I see a wide variety of patients. Oftentimes, the most difficult aspect of their care is finding suitable placement. There are so many factors that limit where a patient can go. Finances and availability in our rural population are some of the biggest factors. Often people have to leave their families and communities to find care. Placement issues can be frustrating for all patients, but in the example of patients going through alcohol withdrawal, it can be very disheartening. Emergency room visits and inpatient hospital stays should be a last resort to treat the condition. Yet, we continue to see the same patients come back through the system. When it comes time for discharge, often we send patients back to their home environments and expect them to stay sober. This is an unrealistic expectation without adequate resources. Learning about systems thinking helps me understand more about what happens to my patients after discharge. I want to help them find the resources to best suit their care. I want to help them find the best resources to suit their care. We do not all live in the same world. Each of us sees the world through our particular lens, developed by our life to this point in time. Therefore, we live in our own world. The nurse has a responsibility to learn about her patient's interpretation of the world to provide maximum assistance for a successful handoff. Financial problems may be the most common barrier to a patient receiving necessary healthcare services. Lack of insurance may result from a conscious decision to not purchase insurance or lack of sufficient resources to afford insurance premiums. Lack of employment or employment in a low-paying job may result in lack of sufficient resources to afford insurance premiums, to have no resources to pay for care, or to earn just enough to not qualify for government assistance programs. The lack of coordinated care may lead to the patient to try to satisfy real or perceived medical needs from multiple providers and levels of service. An individual may be unwilling to personally pay for health care and feel a sense of entitlement. Because most health care is paid by a third party, either insurance or a government program, few individuals know the actual price of health care. This can result in overuse of the system, resulting in higher than necessary costs for third parties or for the private paying individual. Insurance policies and government programs are complicated. The patient may not understand the limitations of payment, such as pre-authorization for procedures, deductibles, uncovered services, and so on. New fees are added without notification to patients. An example is the recent facility fee that hospital-based providers are permitted to add to the procedure or encounter. The patient's health records are legal documents. Incomplete or incorrect medical documentation and coding may result in medical errors such as misdiagnosis leading to unnecessary services or lack of necessary care. Billing for services relies on accurate documentation and coding. Medicare reimbursement regulations have several elements that can result in high personal costs to patients. One example is the hospital observation patient, which allows the hospital to hold a patient as an outpatient for up to 3 days, while physicians determine if the patient qualifies for admission as an inpatient. This observation status is being challenged as there are significant financial implications for patients. You may consider legal barriers to healthcare to be outside your realm of responsibility. However, You may be the only caregiver trusted enough by the patient to learn such a concern exists. Be a good listener and observer. Although there is much information about advance directives, too few patients have made the effort to develop this important document. Lack of advance directives may result in unnecessary services and family arguments. You will do your patients an important service by recommending each person document personal decisions regarding health care under certain situations. A vulnerable adult is an adult whose circumstances cannot be altered or improved by the adult's own individual actions without direct assistance from a more typical adult. The vulnerable adult must also be shown to be, on some significant level, at risk if assistance is not provided. A vulnerable adult may sometimes be denied treatment or may be forced to submit to treatment not in their best interest by family members. If you identify an vulnerable adult, you have a responsibility to report that information to someone within your organization or outside your organization to ensure legal needs are met. Family dynamics play a role in the life of most every patient. When there is dysfunction, you may need to advocate for the patient or may be obligated to report to someone within your organization to deal with the impact of the dysfunction on the patient. Patient-requested treatment may not be possible because of licensing laws. Such treatment may include unapproved pharmaceuticals or practice limitations. Similarly, the provider or practitioner may be required to perform against the patient wishes because of licensing laws. Medical errors can result in legal action that may affect further treatment for the patient or inability of the provider or practitioner to continue to treat the patient. The patient's health records are legal documents. Incomplete or incorrect medical documentation and coding may result in medical errors such as misdiagnosis, resulting in improper treatment. Erroneous medical documentation also results in reimbursement issues and can lead to misinterpretation of the facts by an outside party, such as during a lawsuit. Language, culture, beliefs, and education have become enormous barriers for healthcare providers and patients over the past decade or so. Stereotyping and biases, whether by the provider or the patient, will compromise the ability of each to work together effectively. English is the accepted language in North Dakota. When patients or providers are not proficient in the English language, there is a possibility of an important misunderstanding, or even lack of understanding. Providers should have interpreters available when necessary to meet the needs of the majority of patients with limited English. With our growing diverse population, it is important to know that some patients may have a different understanding of the meaning of life and limb, may have traditional historic practices that do not meet our understanding of good health practice. Unless the patient request is illegal or outside your realm of professional ethics, you should attempt to meet the patient's requests. Take your questions and concerns to your supervisor. Qualified social service agencies and professionals may be in short supply to meet the needs of some segments of the population. The patient may have a lifestyle that requires your flexibility to treatment and coordination of care. We may judge a patient by their dress and appearance. It is important to get past your personal bias to understand the real patient. When you are uncertain as to how to approach or understand the patient, get help from someone to ensure you are fulfilling your professional responsibility. Most of us deal with generational barriers on a daily basis in our personal lives. Within the healthcare arena, these complications become more than an annoyance and can compromise our ability to give and receive necessary healthcare services. Generational barriers exist between providers and patients, and within the provider population. These barriers are apt to complicate communication. As the healthcare provider, we have the major responsibility to make every effort to get across these barriers to teach the patient in a meaningful way. Baby boomers, Generation X, hypochondriac, alcoholic, codependent, and similar labels may lead us to assume the patient has the characteristics we associate with that label, and take away our incentive to know the individual within the grouping. Social media has changed the way we communicate with each other and has changed the scope of information and knowledge. In the reverse mentoring situation, the mentee has less overall experience, typically as a result of age, than the mentor, who is typically older. But the mentee has more knowledge in a particular area, and as such, reverses the relationship. Examples are when young internet or mobile-savvy millennial generation teens train executives in using their high-end smartphones. It seems that each generational grouping has a different understanding of work and life habits. It is important to understand how the patient sees health status in this arena. The healthcare provider and the patients should come to a common understanding of the value of technology in the health of the individual. Technology is an adjunct to health status and health care, not a replacement. The nurse and the patient will each need to be flexible to permit the other to experience a successful encounter. Is good enough okay for the patient, but you expect perfection? Or vice versa? There may be several methods by which to reach a desired goal, and the nurse and patient should come to an understanding of what is acceptable. In the end, it all comes down to communication. Are we really listening to what the patient means? Are we really telling and showing the patient to meet his or her understanding? Geographic barriers to obtaining health care may not be a problem for much of the population. We just jump in the car and get to where we need to be. We pay for the motel and meals away from home if necessary. Childcare is available if needed. Not everyone is so fortunate as that. Transportation poses a problem when there is no car or licensed driver, or there is no money for gas or reliable tires, when there is no public transportation close enough to access. For some, even the cost of public transportation is prohibitive. Weather conditions can pose a problem if there is a shortage of providers. Weather may complicate repeat visits. Rural communities and inner city, not so much a problem in North Dakota, share geographic barriers with travel time to reach emergency services. Distance for rural, lack of transportation for inner city. Limited access to some technology, including reliable phone and internet service, and shortage of providers. Some choose to join an established multi-level health system rather than to practice solo. Especially in rural areas, support groups may suffer from poor usage due to pride and confidentiality concerns. The homebound person may not have easy access to communication or diagnostic technology, may have difficulty arranging transportation, and may not have family or outside support to maintain health in the home. Why is care coordination important? You have probably had family or friends speak to you about a failed transition between caregivers, either within a specific patient encounter or between providers and services. The prescription isn't called in as requested. The sending provider fails to let the receiving provider know necessary details, including urgency. Care instructions are given without verifying patient understanding or access to necessary supplies, and on and on. Poor coordination sometimes results when the patient doesn't volunteer vital information or is unable or unwilling to follow through. Care coordination is a function that helps ensure that the patient's needs and preferences are met over time with respect to health services and information sharing across people, functions, and sites, and B, the deliberate organization of patient care activities between two or more participants, including the patient, involved in a patient's care to facilitate the appropriate delivery of healthcare services. Coordination requires the transfer of correct information, support for the patient to move toward wellness and well-being. This implies there should be a mechanism for tracking how the patient responds to the coordination between care providers. There may be little effort by providers to follow up with patients beyond the satisfaction survey for the current encounter. Successful care coordination will lead to less waste and expenditures caused by duplicate testing, unnecessary referrals, unwanted specialist to specialist referrals, and failed transitions from one provider to the next. Patients in the healthcare system would experience fewer problems with smooth coordination. Clinical practice is more rewarding when you know you have made every effort to help the patient meet his or her expectations. The overall population would be healthier if care for individuals was coordinated by someone with knowledge of the patient as a person, as well as a diagnosis. Coordination could also encourage increased personal responsibility for individual health status. The profession of nursing has evolved over the years to require much more than just caring. Although caring remains at the core of a nurse who is most trusted by patients, today's nurses find themselves in a complicated world of diversity and technology, with social and legal issues. Voices and demands from many directions take away from hearing what the patient speaks. A search of the internet reveals a variety of articles describing characteristics of a nurse. These are a selected few. The lists include empathy, detail-oriented, communication, intuition, physical endurance, emotional stability, critical thinking, coordinator of services, patience, dedication, sense of humor, professionalism, diligence, compassion, sense of deeper understanding of life, sense of hope for what others may seem hopeless. Nurses never say never. Sense of pride in saying, I'm a nurse. This modified Hippocratic Oath was composed in 1893 by Mrs. Lystra E. Gretter and a committee for the Farrand Training School for Nurses in Detroit, Michigan. It was called the Florence Nightingale Pledge as a token of esteem for the founder of modern nursing. I solemnly pledge myself before God and in the presence of this assembly to pass my life in purity and to practice my profession faithfully. I will abstain from whatever is deleterious and mischievous, and will not take or knowingly administer any harmful drug. I will do all in my power to maintain and elevate the standard of my profession, and will hold in confidence all personal matters committed to my keeping, and all family affairs coming to my knowledge in the practice of my calling. With loyalty will I endeavor to aid the physician in his work, and devote myself to the welfare of those committed to my care. The patient encounter should be the primary concern for the entire healthcare system, for the purpose of helping the patient to achieve desired outcomes. Although patients may want results for the actions of the provider, the encounter should include discussion of self-responsibility. The patient decides a health or medical condition requires treatment. In many cases, an initial setting is performed by the nurse. The practitioner sought by the patient assesses the patient and establishes diagnoses of the reason for the visit and, in some instances, also considers all other diagnoses. The practitioner prescribes and initiates treatment. Where a nurse is present, the nurse performs a discharge nursing assessment to plan for next steps. The patient and practitioner representative, maybe a nurse, make plans to reach the next step towards meeting the patient's preferred outcome. The patient is handed off to the next step following this encounter. This may be to another practitioner, to a different service, or to patient self-responsibility. Here, it is important that the patient expresses a clear understanding of results of this encounter and next steps. The patient is responsible to comply with the plan or not, which implies the patient has been given adequate usable information and resources to make that possible. The primary provider-practitioner encounter is how the patient proposes to fix the reason for the patient encounter. Not every encounter will include nurses. The patient is admitted, learning demographic information, billing information, reason for the visit. The provider practitioner assesses available information, including preferred outcome by the patient. The patient may be referred for diagnostic testing. The provider practitioner reviews records and reports to make a diagnosis. The provider practitioner determines the necessary treatment and makes plans with the patient to proceed. The entire encounter is documented. The patient is discharged, handed off from this service, and referred or instructed for follow-up to reach the desired outcome. Documentation is routed for billing. See reimbursement encounter. Note that not every provider or practitioner will admit a patient who has the inability to pay. Hospitals are required to admit anyone for emergency services regardless of the ability to pay. No other provider or practitioner has the same requirement. The treatment prescribed for the patient may be determined by insurance coverage rather than by patient or provider practitioner preference. Some providers or practitioners may deny services to a patient who fails to make payment for services. The nurse encounter extends from beginning through the end of the patient's visit for service, even though there may be a succession of nurses involved in the encounter. Although there is a succession of nurses during the encounter, the nursing department provides the best possibility for continuity of contact. Nursing documentation will indicate where the patient originated from and mode of arrival. A nursing assessment is conducted and documented. The nurse treats and cares for the patient, implementing medical and nursing orders, and coordinates services between disciplines. The nurse learns from the patient's preferred outcome to result from this visit. The nurse considers patient-stated barriers to achieve the desired outcomes and documents. The nurse prepares the patient for discharge, referral, and life after the visit to maintain gains made with training and education. The nurse takes necessary measures for a successful handoff to the next step in the patient's journey, including patient acknowledgement, communication, help with referral contacts, and so on. Reimbursement encounter is the last step in the patient's visit for service. Reimbursement may seem outside the realm of nursing, but the question of finances often drives the treatment or lack of treatment for the patient. Steps involved in obtaining reimbursement for services follow a pretty established pattern, no matter who is responsible to make payment for the health or medical service. Providers or practitioners have staff members responsible for specific steps in the pattern. Ability or inability to pay may determine if a patient receives services. Inconsistencies in documentation may result in denial of payment or even a charge of fraudulent billing. Medical procedures or scheduled treatment generally require pre-authorization. After the service is provided and documented, medical record staff will transcribe any dictation, then assess all documentation. Coding staff will analyze documentation to determine all diagnoses and procedures. Codes are assigned to the diagnoses and procedures in priority order. Medical records submit the codes to the billing department for determination of pricing. Billing submits the bills for reimbursement to the responsible party. In some settings, there is a report handoff between shifts or caregivers. This communication should involve the patient, so there is understanding regarding the plan of care, and the patient can ask questions and give input. A handoff should be the core of the discharge of a patient from an encounter in any setting by any healthcare provider or practitioner. The discharge and/or referral imply the patient is moving into a continuation of fixing the problem that prompted the encounter. This handoff includes information gained from initial and subsequent assessments, observation of response to treatment, documentation, planning for the future, and communication and education to ensure the patient is moving in the right direction. If your employer has no established system for effective handoff for every patient, internally and externally, you may develop your own, and lead your employer to develop a system that covers every patient encounter. Each nurse who does this has the ability to make one small change to improve patient outcomes. You now have an understanding of the complexity of the healthcare system in terms of providers, services, and the long list of barriers the patient may face. The better you concentrate on the patient's specific needs, the better you are able to conduct an effective handoff towards the patient's desired outcome. Studies have shown frequent limited or lack of effective communication between providers when a patient is referred. Although the study depicted here, an environmental scan of health and healthcare in North Dakota, concerns rural hospitals in North Dakota, the problem is prevalent between every type and size of providers. There are usually a variety of options available for patient follow-up from the current encounter. The options may lead to acute care for a cure, or to long-term or chronic care services, either at home or in a facility. Initial consideration is given to well-known options such as licensed providers and services. Because of implication of barriers, there may be other more viable options for the patient. The provider and patient may not always agree on recommended follow-up. The Department of Health website contains names and contact information for state licensed and certified facilities. That website also includes some children's services contacts. The Department of Human Services has several contacts for adult services. Knowing the patient's preferred outcome will help you suggest or look for proper resources. North Dakota has a variety of mental health and substance abuse treatment centers. Some are outpatient only, some inpatient only, and some are a combination or they may offer a choice. There may be a problem with immediate access to mental health and substance abuse treatment because of limited capacity or lack of pay source. You will best help the patient if you are aware of support groups or alternatives and the contacts to help connect the patient for the short term. Whether included in your position description or revealed in your paycheck, you, the nurse, are the piece that completes the puzzle of the patient encounter. You know all aspects of the patient better than the other caregivers and are in the best position, the trunk, to meet needs and desired results together. Because of your training and experience, you have picked up on what the patient really hopes for and what is realistic. You know enough about the barriers the patient faces to ask pertinent questions and offer guidance to a workable solution. Your position as the nurse is more important than your personal relationship with the patient. It is important that all nurses involved with the patient pool their knowledge and skills for this patient, so all your faces and voices meld together into the nurse.
To earn your Certificate of Achievement in Leadership Development, you will need to submit the following: evidence of completion of the 4 leadership modules. Complete one project at the end of each of the modules that demonstrates your application of knowledge, skills, abilities, and judgment of the content from each module. You can see each individual module for those ideas. Use a format that lends itself to professional presentations: electronic poster presentation, PowerPoint presentation, videotape presentation, evidence of presenting project to a professional group, a manuscript for publication, or other method. Collect all your projects into a portfolio, preferably electronic, and submit at the end of the 4th module. To earn your Certificate of Achievement in Leadership Development, you will need to submit the following for navigating the Complex Health System module. Describe your employer organization using the outline provided. Define your present position within the employer organization. Perform and document a successful patient handoff, noting the following: the patient's desired health outcome, assessment of each of the listed barriers, individual or agency's involvement in the handoff, remember the patient in that, elements of the handoff, and the results 2 weeks after the fact of the handoff.